So I realize I'm the last speaker in this session, which I feel comfortable with since that's what I usually am. There's some immune checkpoint exhaustion going on here, and most of you are looking out the window, but you just check in for the next 15 minutes. I think there's some interesting things we're going to talk about. I am going to draw from the melanoma experience because I think they really led the way. They understand really the potential toxicity of these agents, perhaps more than we do. So let's see what we have to say here. So here's my disclosures. I haven't changed since last night, although with my comments I suspect I'll be losing some sponsorship pretty rapidly. So the immune-related adverse events really are events that arise from immunologic enhancement, and they're inflammatory in nature, and they're T-cell mediated to self-antigens. From the really the mother of all immune checkpoints, ipilimumab, we're aware that really this affects all organ systems: the gastrointestinal, liver, skin, respiratory, endocrine, neurologic, the blood, cardiovascular, musculoskeletal, renal, and eye. So basically, any system in the body can be affected and potentially lead to some toxicities. We're going to talk a little bit more about this, but first let's talk a little bit about CTLA-4 versus PD-1. We're aware of the differences in the agents. We've heard a lot about the biology. I'm not going to dwell on that. But I don't think we talked about the knockout models that exist. The CTLA-4 knockout model in mice leads to death related to myocarditis and pancreatitis. Knockout model in PDL in mice doesn't lead to death. Actually leads to some splenomegaly, some lymphoid expansion, but they lead normal and healthy lives with PD-1 knockout. That's probably not exactly true in humans, as we'll see. So again, if we look at the CTLA-4 blockade, the common events are rash and diarrhea. Less common are hepatitis and endocrinopathies. A number of rare events here, but significant events. They don't happen often, but when they do, they're striking. Dave mentioned a case of limbic encephalitis that was fatal, I think. Yeah. Right, and so we had a fatal episode of myasthenia gravis in a patient. I'm sure we're going to see more and more of these fatal events from these well-tolerated immune checkpoint inhibitors. If we look at the meta-analysis from melanoma with IPI, one can see that the severity of reactions grade 3 and 4 are about 20%, but overall there's about a 70% adverse event rate. So there are common reactions that occur. Most of them are not serious, but some can be. We've seen the kinetics of this before, but I think there's a better slide I'll show you that I think speaks to this better than this slide does. Here we go. So to me, it's not the point. Okay. So if we look at the PD-1 blockade and their immune checkpoint adverse events, we don't have things that frequent. They're less common than they are with the CTLA antibodies. But again, rash and diarrhea do happen. Hepatitis and endocrinopathies in particular we should pay attention to. Less common but also quite serious are pneumonitis and other events. So if we look again from the melanoma data and look at nivolumab, we have diarrhea at 8 to 22%, rash at 4 to 26%, pruritus fairly frequent. It's sort of an interesting side effect we don't see with a lot of other agents. The pneumonitis rate at 1 to 5%, so quite similar to what we see in the lung cancer situation, and then hypothyroidism, transaminitis. So this may be a little harder to see, but the other advantage of looking at the melanoma database is we can look at large numbers of patients with single agent nivolumab versus a combination of nivolumab and IPI versus IPI alone. And one can see that skin reactions are fairly common in all three subgroups. GI side effects go up substantially, particularly with serious colitis, much more common with IPI, and then the combination, as well as hepatitis. So clearly there are additive side effects with the combination. And I think this is a more useful slide to look at for toxicity. So toxicity onset, the median may be 5 to 10 or 15 weeks, depending on the organ system, but essentially you can see they can start within days or weeks of initial therapy, and they continue onward as long as therapy continues. So really, one has to remain vigilant, looking for hypothyroidism and other events really throughout patients' treatment. If we look at now at some of the more specific lung cancer data we have, This is checkpoint 17, nivolumab versus docetaxel. And the comment of well tolerated really comes from this slide, but basically what this is saying is that the rate of toxicity is lower with nivolumab than docetaxel at 58% versus 86%. But and the serious reactions are less, grade 3 to 5, 55% versus 7%. So that's where we get the well-tolerated comment. But in fact, if one looks on the next slide, and we look at the grading, one can see if one looks across the non-hematologic toxicities, endocrine, GI, hepatic, pulmonary, renal, and skin, one can see that there is relatively similar incidence of severe grade 3 and 4 outside of GI, which is actually fairly similar as well. So the non-hematologic toxicities are quite common. Now, if one looks at the individual events that patients report, fatigue, nausea, decreased appetite, asthenia, diarrhea, they all are occurring, granted at relatively low rates in the nivolumab group versus docetaxel. But one has to remember that docetaxel is given on an intermittent schedule for a limited period of time. The difference with the immune checkpoint inhibitors, fortunately, these are chronic therapies. Patients are on them longer term, so even mild side effects can be significant for the patients. Now, if we look at the next slide, with Pembro, we can see roughly similar events. We don't have the comparator with docetaxel. One can see the rates of hypothyroidism, 6 or 7%, the GI side effects of diarrhea, nausea, vomiting, and constipation, hepatitis, and the pneumonitis rate. So it looks like nivolumab and Pembro will be very similar in terms of their overall side effect rates. And again, these are some additional side effects seen in this population. The atezolizumab data, I think, is nice graphically because one can see the differences between docetaxel and atezolizumab between the two arms of the study. One can see particularly the immune-related events related to hepatitis, pneumonitis, colitis, and hepatitis to be considered in this group. Just briefly, just some of these individual reactions. What I would call your attention to, the rash, I think we're comfortable managing across a number of diseases. This is a nice paper by Leslie and the oncologist a couple of years ago, looking at grading of reaction and also looking at management of skin toxicities. I think the side effect I'd like to bring to your attention is colitis. So colitis, we're used to managing in a variety of different settings, but we've managed it prior to this era largely with agents that block diarrhea. But this is a different type of colitis, a different type of diarrhea. And so it happens much more commonly with IPI than it does with nivolumab. Our friends in melanoma have learned to manage this perhaps better than we have, because here it takes a very different interaction. You can treat mild diarrhea and colitis with loperamide and usual management, but really once it gets to be more significant, patients need steroids. They need them very quickly and in high dose. And often they need more than steroids. They often need infliximab. Fortunately, this is a less common reaction with the PD-1 drugs, but as we move into combinations, as we use more IPI, we're going to see this, and this can be a fatal reaction if it's not managed quickly. It also takes, it's often a more persistent reaction and often requires longer-term therapy. So this is a problematic side effect of immune checkpoint inhibitors. So with the endocrine side effects, again, a relatively new class for us to manage compared to other drugs we use, one can see a range of toxicities from hypophysitis to adrenal insufficiency to hypothyroidism to thyroiditis. And these can sneak up on you in our population. Patients, you may not pick up patients adrenally insufficient on therapy because they're fatigued and they have other problems going on, but very important to recognize early and intervene. So if one looks at the checkpoint 67 trial and looks at Nivo alone versus Nivo IPI versus IPI in the melanoma population, one can see that the rates of hypothyroidism and hyperthyroidism are substantial with nivolumab alone and are increased with the combination. So again, something we have to look for and manage. Hepatitis, again, a side effect to look for in terms of monitoring liver enzymes, holding drug appropriately, and steroids if no improvement. There's a number of other toxicities we could talk about and go through every organ system. We won't do that. The management of most of these is recognition and early intervention with immune suppression. Pneumonitis, of course, is one other toxicity that I think we always are thinking about. It's often harder to pick up in our population because of other reasons for shortness of breath, but when patients call in short of breath, we have to recognize this may be in the differential and bring the patients in sooner to be reviewed. I did want to talk a little bit about, again, this comes mainly from the melanoma literature, about the interaction of immune reaction and outcome of patients. So first, this is again from the IPI data, but it looks, at least from a small series, that if patients have more severe immune reaction, grade 3 and 4, they're more likely to have a clinical response than less. So this is sort of an interesting phenomenon. I don't know that we've recognized this yet in our data in the lung cancer space, but it suggests there may be a relationship with degree of immune adverse event and clinical response. And then what about immunosuppression? When we're giving steroids to block the reaction we want to see in the tumor, is that having a negative outcome for our patients? This comes from a study by Troy looking at their institution at Sloan Kettering and looking at ipilimumab at the 3 milligram per kilogram dose, 300 patients, and they looked retrospectively in melanoma to see what the impact was of steroid use. You can see almost a third of patients got steroids in their center, a number of them grade 3. You can see the range of side effects. Some end up being infliximab because of persistent diarrhea. So what was the impact? Well, if one looks at a landmark analysis in terms of survival, the upper curve show no steroids versus steroids or any toxicity. And one can see really there was no evidence from their retrospective study that the use of steroids in a third of their patients adversely impacted outcome. The bottom curve on the right in D shows no steroids versus steroids, with the steroids patients looking a little bit better, but at least I don't think we should be worried about the use of steroids to manage patients appropriately when we see these side effects. So in conclusion, immune-related adverse events are T-cell mediated inflammatory events. The early initiation of immunosuppression reverses most of these, but not all. Some of the neurologic events, unfortunately, are irreversible. We need to understand them better and figure out how we might intervene. CTLA-4 inhibition is clearly more potent than PD-1 inhibition, both on the immune system and on the host. The combination leads to greater toxicity. Steroids do not, at least in a small series in melanoma, appear to adversely affect outcome. And grade 3 and 4 immune reactions may, in fact, be a positive predictive marker, again, in melanoma. We'll see if that plays out in lung cancer. And then last, we had a debate at the World Lung Meeting about chemo versus immune checkpoint inhibitors, which are better, which are safer. I think we can say this, that both chemotherapy and immune checkpoint inhibitors have unique and potentially life-threatening adverse events. If we're going to use these safely and effectively, we really have to key our staff and nurses in to understanding that one needs to respond differently to colitis in the setting of an immune checkpoint inhibitor than we might routinely with docetaxel, for example. In the end, I think our patients' experiences rather than our own opinions are really going to dictate how well these drugs are tolerated and managed. So thank you.
Thank you, Joe. So you didn't mention financial toxicity. Right. So, you know, one thing that you didn't really talk about that I think is going to become more of a problem is late toxicity after therapy. So I had a patient that got a few cycles of Nevo and progressed, then went on to chemotherapy, had a nice response. And he wasn't feeling well one day, and I checked his TSH. It had gone from normal to greater than 150, like 6 months after finishing his immunotherapy. And it was just an interval of about 2 months from a normal TSH to greater than 150. And then, so we started replacing him, and then he was getting chemo, and he ended up with an admission for febrile neutropenia and was very hypotensive and was found to be hypoadrenal also. And so even though the patients progress and they're on subsequent therapies, You know, when we've long forgotten about the immunotherapy, these people are at risk of developing these late toxicities that can really impact their care down the road if we don't recognize them. So we need to keep that in mind.
I think it's a great point, Dave. That's why I showed that the idea when you see that kinetic curve, people think about the rate of onset at 6 weeks, and after that they're fine. But really, you've got to continue to follow these people long term. We have a patient that on a preoperative treatment of carbotaxol IPI had trouble getting through surgery and finally got it home, but failed to thrive for a month or two. Finally, was recognized to have hypoadrenalism. So same kind of story, just about died from this, and this was 3 months after therapy that it was recognized. So we have to be vigilant about looking for late toxicities. The other point is, while we're saying a lot of these are reversible, the endocrine abnormalities, they're not reversible. I mean, okay, you can take thyroid medicine for the rest of your life, that's fine.
Yeah.
But I have a patient that got nivolumab that has insulin-dependent diabetes. They finished their nivolumab a year ago. They're still taking insulin. So it's not a short-term side effect.
That needs to be kept in mind throughout the life of the patient, not just
Absolutely.
during therapy.
Absolutely.
Other questions?
When, because of that, it's not going to just be the oncologist. And, and the group here may get very sophisticated in thinking about that, but these patients are going to come into ERs and they're going to come into ERs around it. How do you, and at Duke, and how are you kind of looking at potentially educating the other doctors in the care of the patient to recognize these early, so that, especially the late, as you mentioned, they may be off the immunotherapy, they may be taking chemo, or they may be doing well and just being watched. And so how are you educating your community for these toxicities?
Sort of how they're educating us. I think I had a last slide. I'm thinking put it back up. But I think what's happened in the at Duke at least is that we're getting a lot closer to our other subspecialists, right? So we reach out to our endocrinologists, we reach out to our neurologists, and I think it's a really Venn diagram with the medical oncologist in the center.
When they show up at an outside ED, that's...
So one more slide. Other way. There we go. So this is really what's happening. We're really needing, we've always been multidisciplinary in our care model, but now it's much more multidisciplinary. So I think it's partly us being educated by all the other subspecialists, because we're now the primary care people seeing these people. And so we have to know when the toxicity is developing and then reach out to them at appropriate times. And I think really training the triage nurses and others taking these phone calls how to address this and understand, particularly if someone's on, when the nivolumab's one level, when they're on a IPI, it's a whole nother level of really appreciating and responding quickly to side effects.
So one way we're trying to address that at Ohio State is with a cancer-specific ED. So if you have a cancer patient that needs an ED visit, they go to the cancer ED. And those people hopefully will be more aware of these kinds of things.
Yeah, that's huge. Most of our patients are bouncing into an ED someplace with no idea. They can't
Right.
spell these drugs, let alone the side effects.
Right. Okay, so we are going to skip